How do you get a loved one with bipolar disorder or schizophrenia to stop using substances which have contributed to or triggered psychosis in the past?
Ask them about what it's like to get high. This is a fundamental psychological truth. People want to feel heard. Then explore with them what's negative.
My loved one is medicated and stable, but the voices are persistent, and I cannot convince my loved one that they are not real.
Validate, absorb your loved one's experience. Don't contradict it. Don't counter it. Don't try to talk them into something. Logic and argument typically makes things worse.
How does one navigate HIPAA handcuffs when there's an estrangement and your loved one will not sign a release of information?
You get a hold of your loved one's provider. I know you can't talk to me about my loved one. I know you can't even tell me if you're treating my loved one. But hey, I know you are. I have some important information. Can I share it with you?
It's very good to see you again, Dr. Amador. I'm so glad you were able to join us so that we could get through some more of our questions. So I'm going to start with a question from Michael. How can someone with schizophrenia or schizoaffective disorder who is otherwise stable, medicated, and functioning well avoid or mitigate spikes in symptoms in high stress environments and situations?
A really great question. First and foremost is talk with a loved one and or your provider about warning signs that symptoms may be reappearing, and be open to feedback and ask people to check, to let you know, like, hey, you're starting to talk about this idea that you used to talk about before, and you don't sound delusional, but you were at one time about this particular idea. So the trick really is to first discover what the warning signs are of the onset of an exacerbation of symptoms, and then get a team together, loved ones and your provider. Make sure they know and they agree. Maybe they have some ideas of what the warning signs are, and then ask them to give you that feedback.
If you know that your loved one has something stressful coming up, and I guess what I was thinking about is that my sister just recently had to have surgery unrelated to her illness, but I figured that was likely to be sort of a stressful event for her. Is there like a good way to talk to somebody to like really put on their radar that like, hey, you're about to go through something that's likely to stress you out that could actually make things worse with your symptoms? Or is it unhelpful to do that?
I would say it exactly like you said it, word for word. Like, you may have you're about to go through something really stressful, and it may make some of your symptoms worse. And I'm here to talk about it. I'm here to help you if that happens. Stress does exacerbate symptoms.
Yeah. And I think, sometimes that's actually one aspect of anosognosia that I think of as being, a lesser known kind of symptom of it is like kind of not necessarily recognizing when something is like potentially worse than normal, or like if there's a reason why you may actually be symptomatic when you're not normally symptomatic. It can be as simple as just like, hey, if your like daily routine is disrupted, then like your medication schedule might get off, and that can still affect you. And you may not necessarily recognize, like, I feel different. There might be a reason for that. So here's another question from Anonymous. I do not have anosognosia, but I find that other people using LEAP techniques with me helps me engage with my treatment and drop defensiveness. How can I approach and encourage people to engage in LEAP with me to help my relationships? I explain to people that using LEAP with me will improve our relationship, but they feel I am telling them how to act or feel, that it's my responsibility alone to manage myself.
I love that question. And LEAP was created to help people with anosognosia, but it's utilized with everybody. I use it with my son. I use it with my wife. So I really love that he or she is feeling that it's useful. To answer the question, just say, I really want to feel heard, and I'm not feeling heard. Could you do a little active listening with me? And you can teach them what active listening sounds like by you doing it for them. What I hear you saying is, I'm being too nitpicky about the way I talk. Is that what you said? Did I get that right? Role model it for them. But the way to start the process or the conversation about they're using LEAP techniques with you is to say, I really haven't felt heard. I'd like to feel heard. Because that is the central, core goal of LEAP is that people feel heard and validated.
Do you feel like people, kind of need to understand what LEAP is in order to sort of pick it up?
And what you could do is send your loved ones to leapinstitute.org, and there's under resources, free videos. There's a dozen videos on LEAP, and just go through them and watch them and pick the one that you think would be best for your loved one.
Yeah, and I'll tell you, I did that exact thing not that long ago. I've got a friend who's experiencing some concerning issues with her brother, and was trying to figure out like what's the best way for me to approach this with him because he doesn't think there's anything wrong. How do I have this conversation so that it doesn't just get shut down immediately? So I, went to your website and grabbed a bunch of different links and sent them in an email, and they were really grateful to have that as just like a framework for how to even just to practice talking about things with each other
Mm-hmm.
before they talk to him, to just like make sure that they have a plan. I mean, I like to tell people that generally speaking, having a plan is going to make almost any conversation go better. And honestly, even if the thing that you're afraid of happens, if the person has like a very negative reaction, they get angry, the fact that you've kind of mentally explored that that is one possible option is something that is useful. It's less
Mm-hmm.
scary if you just acknowledge like this might happen. And
Right.
if it happens, it happens. So I
Yep.
definitely think that, practicing LEAP and kind of having that conversation with people about like it's really best if we can talk about it in this way is a really great way to just kind of overall incorporate that into your life in a way that makes it part of everyone's life around you. Another question from Michael, I don't know if it's the same Michael. Question is, when two people with SMI are partnered in a relationship, how do you avoid one person's symptoms triggering the other person's illness? For example, when the partner's paranoia sets off paranoia symptoms in the other person.
Talk about it and ask your partner, would you mind not talking about this topic so much with me? Can you talk about it with someone else? Because it triggers me. Ask them. I mean, this is a different situation, but I was really anxious about something for about a month and a half, and I kept ruminating about it and talking about it. And my wife said, it's triggering me. It's really triggering me. Could you stop? Would it be okay? Can you talk with somebody else about it and talk to your therapist about it? I have a therapist. And at first I was a little bit like, well, but you're my partner. I should be able to talk to you about anything. But then I realized it's hurting her. It's triggering her. And I was able to stop doing it. And it helped us both. It helped our relationship. And it actually helped me to be less anxious. So I think that applies to delusions as well and paranoia, that ask your partner, would it be okay for you to talk less about it in front of me and talk more about it with other people?
That's good advice. And it's definitely, something that I think it's a good idea for people to recognize that you shouldn't try to get everything that you need from one person. And you
Right.
have to be thinking about like, what is the impact of what I'm saying on the person that I'm talking to? So I've got a question from Ellie. What does the research say about people who are medicated and otherwise stable who still have persistent auditory hallucinations? My loved one is medicated and stable, but the voices are persistent, and I cannot convince my loved one that they are not real.
Well, first, I wouldn't try to convince them they're not real. If you've tried and it hasn't worked, please, by all means, stop doing that, because all it's going to do is create tension in your relationship. Uh, what you can do is find somebody who does CBT for psychosis. The research is really, really impressive in terms of reducing the intensity and frequency of hallucinations. So there's talk therapy that can help with that. But don't keep trying to convince your loved one that the voices aren't real.
So, kind of going a little further down the road to talk about CBTP. This is something that research kind of demonstrates is like vastly underused with the population. So we
Yeah,
have a tendency to
yeah.
only treat with psychiatric drugs and kind of ignore the additional benefit that can come from having a therapeutic relationship that's based on something other than just medication. Can you talk a little bit about kind of what that's like and how it can be useful for people generally, and if you have any tips about how to try to find people who are able to do that kind of therapy?
Well, in terms of trying to find somebody, go to the beckinstitute.org, BECK institute.org. Email them and ask them for anybody who's gone through their CBTP program. They're leaders in the field in the United States. There's leaders, especially in the United Kingdom, where CBTP is used a lot more often.
Maybe we
It's,
should. Well, maybe we should start by saying what CBT is. So that's cognitive behavioral therapy. For people who don't
right.
know about it, do you want to say a little bit about like kind of what the overall underpinning is of it?
Yeah, basically you're helping the person identify thoughts that are causing problems for them. So, and they're called cognitive distortions. So I may have the thought like I'm stupid, right? And then you learn techniques like the catch it, check it, change it technique, which is catch the thought. I found myself thinking I'm stupid. Let me check it. Well, I was able to do this. I was able to do that. I got a high school degree. Maybe I got a college degree. I'm not so stupid. And you change the thought. So that's just one example of many tools you learn in CBT. So it's very cognitive and behavioral, right? It's changing your behavior, but in relation to identifying cognitive distortions that you have. And so the same principles apply to psychosis and psychotic symptoms and identifying voices. And the CBT therapist isn't going to get into whether the voices are real or not. That's not relevant. It's just whether they're distressing the person. And if they are, then they teach them techniques, thinking techniques to reduce the intensity and severity of the hallucinations.
I wish that we had better incentives to make sure that that was part of people's treatment. We'll have to think. We'll have to do some brainstorming about how to incentivize that kind of treatment with our current system. Just because I like it, definitely, it seems like such an obvious thing to like help people, give them techniques that they can use to counter things that are causing problems.
Yeah.
Here's a question from Maureen. When your loved one is a little stable due to initial medication success, is it helpful for my loved one to listen to the podcast? What supports are helpful to put in place in the early days of recovery process due to medication success?
I think if your loved one does not have anosognosia, they have some insight. I think our podcast could be very helpful. But I think the questions that we've been discussing are relevant for somebody who's in the early stages of recovery.
I guess what I think about that is that it has to be something that they want to do. I mean, so like I definitely have
Right.
seen a lot of people who really resist, wanting to dwell on that kind of thing. And I wouldn't, I certainly wouldn't ever tell someone that like, oh, you really need to listen to this if they really seem resistant to it. I think it's helpful to just kind of hear the conversation and like kind of recognize that this is a normal thing to talk about. This isn't something that you need to feel isolated about, and to just kind of be part of that conversation and to, and I will certainly encourage anyone who has lived experience with severe mental illness who's listening to the podcast, your questions are definitely relevant. Definitely submit them. And, like your experience is something that, everyone should be aware of and should be incorporating to how they plan this with their loved ones. So I think that like the more engaged that you want to be, the better, as long as people have the sense that, they're always welcome in this discussion.
Yeah. And in terms of the person that asked the question, if you invite I think it was her daughter, if you invite her to watch a podcast, choose one that you think would be useful to her, then ask her, even pause it 10 minutes in and watch it with her and ask her, are you liking this? Is this useful to you? And if she says no, just stop it. Just be empirical about it. Test it out with her.
So this is like maybe like kind of a strange question, I guess, but so say for example, if I were to invite my sister to listen to the podcast, if I said something that
Right.
she really didn't like and thought was inaccurate, like what is the best way to address, like, hey, I've put this out here. I've communicated something. You obviously don't agree with it. What's the best way to resolve that kind of a conflict?
Just to actively, reflectively listen to it. So what I hear you saying is that what you just heard Dr. Amador say is bullshit, and you shouldn't be doing that. And did I get that right? Yeah. Well, I can see why that upset you. It would upset me too. That's listening and empathizing with the LEAP program. Validate, absorb your loved one's experience. Don't contradict it. Don't counter it. Don't try to talk them into something. Logic and argument typically makes things worse. And there's a whole field of research on the emotionality of communication in families, worsening symptoms. So if you're critical or confrontational, it doesn't get you anywhere, A, and B, it can actually exacerbate symptoms of psychosis.
So here is a question that actually come up from multiple sources and like in different places. So I'm gonna kind of paraphrase a little bit so we can try to catch all of it. But how do you use leap principles when delusion and paranoia have estranged your loved one from you? And then kind of like a similar wording that we got is how do you address issues using leap with somebody who just won't engage with you at all?
You got to do an investigation and do it on your own or do it with another loved one in the family. What might our mentally ill loved one be angry at us about? And if you determine, oh, it's because we had that conversation a month ago where we said that they had mental illness and they got really pissed off, let's apologize for that, right? Hey, I'm sorry when we had the conversation last month that I said you had a mental illness. I think that was really upsetting to you. Am I right? Yeah, I'm sorry that I did that. When the delusions involve you, don't be afraid to absorb it, to validate their experience. That's not agreement. So, let's imagine that the person's loved one has said, "You've ruined my life. You're the reason I can't get a job," right? And it's the illness is the reason, or their inability to engage in treatment. So what should you do? I would just reflect that back. So what I hear you saying is that I'm the reason you can't get a job, right? It must be upsetting. Did I get that right? And when the person says, yeah, you got that right, that must be really upsetting to you, right? And then if the person says, well, are you agreeing with me? There's other tools in the LEAD program, which we won't get into right now, but it's everybody wants to feel heard and have their experience validated. So that's all I'm talking about is the principle of validation. And if you're the target of a delusion, don't be afraid to talk about it and to validate your loved one's experience.
Would you say there's is there like a limit to how much detail you want to get into with like why they have a delusional belief? I mean, is there harm that can come from kind of encouraging to explain why they think something? Or should you just acknowledge, I hear that you think that, and
Yeah,
and just kind of leave it at that?
leave it at that. If you're asking questions about why you believe it, in my experience, people, especially with anosognosia, are like, I know what you're doing. You don't believe this. And you're trying to prove to me that it's wrong what I believe. So asking for detail almost always backfires. Uh, Keep it simple.
Yeah.
Less is more. The less you say, the better.
I think like that makes sense because it does kind of feel like it's like you're sort of slipping back into trying to like convince them of something, which is just not what delusions are about.
You can't talk somebody out of a delusion.
So here is a question from Christine that I think will be interesting. So, and this is something that I know like kind of puts the finger on a fear that a lot of family members have. I'm fairly familiar with the LEAP method. However, I struggle with the next step. In other words, if I stop fighting with my loved one to take meds anymore and they choose not to take their meds, then what? Is the suggestion to allow the natural ramifications, i.e., hospital or jail?
Well, it depends. What I'm not hearing in the question is how have you tried to persuade them to accept medication? So there's different ways to do that. One is a personal ask. Would you do this for me? Just try it for a month. Try it for 3 months. Well, why? Just because I'd sleep better at night. I would really like you to do it. And maybe I'm wrong for thinking this, but I think it could help you. So a personal ask, a personal favor is one. The other thing is leverage. In our last Ask Dr. Amador episode, somebody asked about using money. Can you use that to leverage somebody? By all means, if the person wants some money for something other than food and shelter, we don't leverage that. We provide that always. You have the ability to give them some extra money. Why not? Why not leverage that? But you do it softly. You do it with kindness. You do it with compassion. And with apology. I'm sorry that I need this. I need you to accept the medication in order for me to give you this money you're asking for. There's a couple of families I'm working with right now where their loved one wants to live independently, and they want that for their loved one as well. And they said, well, we'll do that for you. We'll rent you an apartment if you start taking medication.
I've definitely heard that one as a piece of leverage that can often be useful. I mean,
Yeah.
I think it's harder to argue with that one, I mean, doesn't mean it wouldn't happen, but so like one thing that I notice in that question that I think I would also just kind of jump in, thinking about what the experience of the family member is. It says, is the suggestion to allow the natural ramifications, hospital or jail? And so I would actually challenge the family, like, you probably can't control that one way or the other. So, like, you have to get to the point where you recognize that not every bad thing that happens is going to be because of a choice that you made or did not make.
That's right. That's right.
It's important not to own, what I mean, like, don't take on more responsibility than you actually have, because that's a recipe for stress and anxiety.
Yeah. And guilt.
Yeah, absolutely. I mean,
No, I agree.
it's easy to feel like you have those that control, but it's actually better if you can recognize that you don't. Here's a question from Celia. What are some approaches to using LEAP for parents of teenagers with severe mental illness and anosognosia? As a parent of a child with SMI, can you offer any advice on getting through to my teen?
Yeah, I mean, I'm gonna sound like a broken record, but when your teen says something that's really irrational and really irritating, and you think, "Oh my gosh, I can't believe that they're even thinking this," don't react to it. Don't contradict it. Listen to your teen. Tell me again what you're saying about how. Uh, Again, I use the example. I'm ruining your life by making you come home by a certain hour. Tell me again. Oh, I can see why you're upset with me. And I'm sorry as a parent. This is what I need. But first, really listen. I mean, look, I didn't invent the power of listening, right? This is a fundamental psychological truth. People want to feel heard. Teenagers especially feel unheard. You're not listening. I bet this person's teen has said, "You're not listening to me." So do active, reflective listening with your teen.
Here is a question from Mary that touches on substances and co-occurring disorder. Question is, how do you get a loved one with bipolar disorder or schizophrenia to stop using substances like nicotine and cannabis, which have contributed to or triggered psychosis in the past?
The way you do that is you ask them about what it's like to get high. You start with exploring their experience, and you might even, this sounds scary, validate it. Given what you've told me, when you get high, you feel at peace, you feel happy, you feel your worries melt away. I can see why you do it. And if that was the effect it had on me, I think I'd want to do it too. So explore with them what's positive. I know it sounds strange. What's positive for them about substance use? Then explore with them what's negative. Do you see any downside? Yeah, I end up doing more than I want to. So that's a downside. Yeah, I can see why that's upsetting. Empathize with that. Is there any other reasons? It costs a lot of money. You are looking at the cost benefit analysis, but you're not doing it.
Mm-hmm.
It's a very Socratic method. You're asking questions, and during the dialogue, you're reflecting back and being empathic. But you start with what's positive about it, which is going to blow your loved one away. Like, what? You want to hear why I like it? Yeah, I'm curious. I've never really asked you what do you get from it? How's it feel? You gain trust. You gain, trust is the big one that you gain.
Yeah.
And openness to you by doing that. Then you can start to explore, what do you think some of the downsides are?
Yeah. I know that people are very reluctant to do that because they feel like they're, tacitly giving permission, that they're saying, like,
Yeah.
they don't want to acknowledge that there's anything positive about it because they're so
When
fearful of
someone
it.
is addicted, they're going to use no matter what you say. So your approval, explicit approval, which is not what I'm suggesting, but even if you explicitly approved, it's not going to increase the likelihood that they're going to smoke meth or do coke or smoke weed. That's not how addiction works.
Right.
When somebody has addiction, they're going to try it. I often call addiction the disease of more. I just want more. The person thinking you're giving them permission is not going to make a difference.
Yeah. Well, I mean, and this certainly does remind me of the previous question that we had about reaching out to teens. I don't know anything that shuts down a conversation with a teen more than just being unwilling to accept that there might be a reason why they want to do something.
Right.
So this is probably going to be a challenging one, and I'm not sure if you'll have a good answer for it, but it's one that comes up a lot. So I'll bring it. This is a question from Phyllis. The question is, how
Okay.
does one navigate HIPAA handcuffs when there's an estrangement and your loved one will not sign a release of information? And then there's a related HIPAA question that came from someone else. That's, how do we get HIPAA laws changed? Which is probably more my
Okay.
area, but
I was gonna bounce that one back to you for sure. So let me answer, then you answer this part two. Part one, the HIPAA handcuffs. What you can do is you get a hold of your loved one's provider and be sympathetic to the provider. Look, I know your hands are handcuffed. I know you can't talk to me about my loved one. I know you can't even tell me if you're treating my loved one. But hey, I know you are. So I have some important information. Can I share it with you? And most providers will listen. Most will, in my experience.
and one tip that we often give is that it's a good idea if you can to fax information that you want to have be part of the record,
Always
because once it's received, it needs to go there. So it's a
do it
way of
in
getting around
writing.
it.
I always give that advice, Lisa. Do it in writing and ask for it to be put in the medical record. But when there's a communication that comes in that is relevant to a patient that's being treated in a practice or a hospital, they have to put it in the medical record. And once it's in the medical record, it does need to be responded to.
Right.
So always in writing, if possible.
If you can't get somebody to listen, it's some things are very important. Like if somebody has had a really negative experience with a medication previously, it's important to get that information into the
Yeah.
record, like even if you're
Yes.
experiencing
Please
resistance.
don't prescribe, whatever the medication is,
Right.
because they had really bad torticollis and they had EPS and they had a negative side effect to it. And if you do write that kind of letter and you can get it or an email to the provider, less is more. Think in bullet points.
That, you know what,
Don't
that
tell
is
your
really
whole
good
life
advice,
story.
because I have to tell you that like one of the first things that we need to do as advocates when people, come to us and they want to either be involved with grassroots advocacy or they're looking to troubleshoot a particular issue is that we've all seen it. There's a book of information because I
I
mean, like
know.
the treatment history that
I've
people
got one.
have, it's, with the revolving door treatment, there are pages and pages and pages of history. And you just have to accept that, like, generally speaking, a doctor they're just not going to read that. You need to
They don't
get
have the time. They don't have
you
the
need to
time.
get in front of them what they actually need to see, and you need to it might feel good to unload the whole thing, but you always have to be thinking about
Right.
your audience and how to get them to take in what you need to take in.
And the letters I help families write to navigate HIPAA, it always start out with, this is my relationship to your patient. I have some information that I believe is vital to your treatment. And then you bullet point it, what the things are.
Yeah.
This person has anosognosia. They do not understand they're ill. They are not going to take medication when they leave the hospital. Let's say it's a hospital that you're talking to. B, anytime they've been on oral medications, they throw it away. Would you consider a long-acting injectable? Third bullet point, that's it. Try to keep it to 3 bullet points. But start with, I have information that I think is vital to your treatment.
Yeah. And I mean,
Start
and
with
they
that.
they should not be disregarding that. And most of the time they won't. I mean, and many people have had very negative experiences with physicians, but it's important to realize that generally they aren't attempting to do things for nefarious reasons. It's just, they're
No.
thinking that they're doing what they're supposed to be doing under the law. And so I
And
will,
they're scared of being sued.
yeah. And so I will jump in and I'd like to talk about how to fix
Yeah.
HIPAA.
How do you fix it? Yeah.
First of all, I'll say that like the reason why HIPAA has been so difficult to deal with, and like why it's been difficult to get meaningful reform on it is because so the reason that it was brought forward was like to protect medical privacy, but not really in this context. It just has ended up being especially relevant in this context. It really was like as medical records became electronic, people became concerned about things going everywhere and not protecting people's
Right.
information. So it came from a good place. But the issue that has arisen and what has made it very difficult to deal with is that what it did is it created sort of a default position of not disclosing things without really thinking about whether or not this is a situation where you should disclose something. And
Sure.
by far the safest thing to do, coming from a lawyer, the safest thing to do is to not disclose anything because you won't make a mistake
Right.
and you will not
Right.
encounter any negative ramifications if you don't disclose, whereas you might if you do. So what has been tried in the past is there's been guidance that has been put out there that is supposed to give like professionals the detail, like, hey, read through, these are circumstances when it would be okay for you to disclose medical information. These are situations that are exceptions to the HIPAA prohibition of sharing that information. I think we can all probably agree that that hasn't really moved the needle at all. I mean, that guidance has been out there for a very long time, and it really hasn't meaningfully changed people's behavior. One thing I will say as a suggestion for family members is if you print that guidance out and hand it to somebody that you're talking to, it might make a difference. They might think about whether or
That's
not.
the question. I was just going to ask you that question. That could be part of the facts you send.
Yes, I mean, it is something that we like have partnered with people. It's like write letters or to like help them script a phone call to make sure that it's like, hey, there is an exception that exists in the guidance. Here's where it is. You can see that this isn't coming from me. This is on the website for HIPAA, so you can see this is actually intended to be an exception for those circumstances. And some physicians will honor that when they can see it, and you can make them feel comfortable that like this is actually intended for you to be able to communicate at this time.
Lisa, is there anybody writing legislation that the person who asked this question could write to and support?
There
That's
isn't
relevant?
anything right now, although there, like certainly whenever there is legislation on HIPAA, we do send out alerts to our list. So I would say, like, if you're not already signed up for our alerts, you should sign up for
Sign
them,
up.
because if something does come through, we will always make sure that people know that they have an opportunity. I think some of the things that have been raised in the past as potential ways to try to encourage different behavior is to create a safe harbor for physicians who are acting in good faith. So like it kind of would, if we can get this through, like, and you have to remember that there's HIPAA laws that are at the federal level, but there's also a state version of HIPAA. So whether or not the federal HIPAA law allows for disclosure, you might have a more strict state law that you also have to worry about. So part of it is just, trying to create situations so that like you can take away the fear that physicians have that they're going to get sued if they disclose information that wasn't supposed to be disclosed. And, I mean, this is something that I don't, for whatever reason, people are particularly worried about it in this area. Whereas like, I mean, I really have never encountered this in like a dementia case or somebody that has autism or somebody that has developmental disability. Like there is a much greater willingness to share medical information with
Yeah.
caregivers and loved ones in that situation. So, it's probably partly because there's stigmatized illnesses even within the treatment field, so people assume that you wouldn't want to share this kind of information as if it's, uniquely shameful or something like that. So part of it,
Hmm.
I think, is going to be to try to, we will eventually need to figure out ways to create, carrots and sticks, which is always what you do at the federal level. You try to provide an incentive for people to have ongoing, like active collaborations with caregivers. And then you try to remove the stick. So like basically if people are worried about getting sued, you make very clear that you will not get sued over this. This is not a situation. If you're acting in good faith, you're not going to be subject to, a malpractice claim or like a HIPAA claim. So that's the method that people have used so far. And, I will tell you that like if anyone has a wonderful brainstorm about like a kind of bill that you could introduce, we're all ears. It's one of the things that has been, sort of an ongoing trouble that we've had is like figuring out what you can suggest as a legal remedy that would kind of get away from this default don't disclose position that physicians have had since HIPAA really went into force.
And is the kind of fact sheet, I don't know if that's the right way to refer to it, of things you can talk about as a provider that you were talking about earlier, is that available?
Yes. So we have a resource on our website. Within our community resources, you'll see that we do have a number of things that are specific to HIPAA, some of which are, techniques for how to get around them. And then there is actual like link to the guidance that says, and it's like, it's lengthy. I mean, all the stuff that comes is but like we can find the part that's relevant and make sure that you can hand it. And it really is worth a try to, include that in a letter, quote it, send a link to it so people can see this is the guidance, the official guidance from the people who promulgated HIPAA. They do mean for there to be exceptions, and that can be useful. But I think ultimately we're gonna have to keep being creative to think about ways to ensure that people don't intentionally, as a default reaction, just cut loved ones out of these discussions. Well, I can see that we're actually over time here, so this is a particularly long episode. So I will wrap it up, and I'll just remind people of how to get in touch if they want to. So if you've got a question that you want to have on the podcast, the best thing to do is to either leave a voicemail at 703-294-6005 or to send an email to per@tac.org. And then if you do want to get in touch with anybody on our helpline, you can do that by filling out the form on our website at tac.org/helpline, or you can call directly at 703-951-9760. And that would be the best way to get a hold of somebody who will contact you back and help you troubleshoot with any questions. And thank you again, Dr. Amador, for taking the time to answer some questions.
Thank you.